Well, good evening, everyone, and welcome to our NANOS webinar, Demystifying Careers in Neuro-Ophthalmology. What is it that we do? My name is Julie Falardo. I'm an ophthalmology trained neuro-ophthalmologist at the KCI Institute, Oregon Health and Science University. And my co-host this evening will be Dr. Collin McClelland. And we're really, both of us, really excited to spend the next 90 minutes talking about neuro-ophthalmology with our very esteemed panel. You will hear this evening about the different pathways to become a neuro-ophthalmologist. Our invited speakers, in fact, came to the field, all of them from very diverse backgrounds, and they all have very different practices. So during the webinar, we really want you to submit questions in the Q&A section. Your questions will be anonymous, and you do have the option to upvote any questions submitted by other attendees if you feel like these are really good questions. We have two wonderful Q&A moderators with us this evening, Dr. Heather Moss, who is neurology trained and Associate Professor of Ophthalmology and Neurology at Stanford University, and Dr. Vivek Patel, who is ophthalmology trained and Professor of Ophthalmology at University of California, Irvine School of Medicine. Both of them, Dr. Moss and Dr. Patel, will be answering your question live in the Q&A section. But they also will be bringing some of your questions to the live webinar to discuss with our guest speakers. So without further ado, I would like to introduce our first speaker, Dr. Collin McClelland. Dr. McClelland is an ophthalmologist and Associate Professor of Ophthalmology at the University of Minnesota, and he will provide a basic introduction to the field of neuro-ophthalmology, including residency and fellowship options. So Collin, you can take it from here.
Thank you so much, Julie, and thank you to everyone for joining, for taking time out of your day. And so this is just going to be a brief introduction to our field, and then you're going to get a lot more input from our panelists as we move along. So how do you get to a career in neuro-ophthalmology? Well, there's three main residencies that you could consider. The ophthalmology residency is 4 years, includes an incorporated PGY 1 year. That was a change that was made relatively recently. And of course, this is going to be a surgically oriented residency and by and large outpatient based. So tonight, these are our speakers and panelists that are ophthalmology trained. So you're going to get some great input into that perspective. Of course, you can also be a neuro-ophthalmologist coming from a neurology residency training background. So typically that's going to be 3 years of neurology and 1 transition prelim year. This is going to be a medically oriented training background with extensive inpatient experience. Of course, that's going to vary from program to program, how much outpatient experience you get. And these are our 3 speakers tonight who have neurology residency training background, and so you'll get some exposure to that. And then you can also pursue neuro-ophthalmology through a child neurology residency, which is a 5-year residency that includes 2 years of pediatrics, general pediatrics, 1 year of general neurology, and 2 years of pediatric neurology. This is also a non-surgical residency. And Dr. Shannon Barris is going to represent and tell us more about coming from a child neurology residency training background into the field of neuro-ophthalmology. So right now, it's an exciting time to enter the field of neuro-ophthalmology. We have 35 accredited fellowships, and that number, even since I put this together a couple of years ago, this talk, the number has increased from 27 to 35. So if you want the full listing, you can go to the NANOS website and find that easily. And you're really going to get diverse training experiences depending upon where you go. So all of the fellowships are 1-year fellowships, but you may, depending on which fellowship you're looking at, have 1 to 6 clinical mentors, and the training of those mentors may vary. Some programs have all ophthalmology trained mentors, some will have all neurology, and some have a mix. All neuro-ophthalmology fellowships will provide you great medical training, and some will provide surgical training as well. So in regards to surgical neuro-ophthalmology, approximately 50% of practicing neuro-ophthalmologists perform surgery. This is based on a 2016 internal NANOS survey, but this is a general estimate. And the major surgeries that are performed include strabismus surgery, orbit surgery, and cataract surgery. So anyone who completed an ophthalmology residency would, of course, be trained to perform cataract surgery, but many neuro-ophthalmologists do not continue to perform cataract surgery, and some do. There's also a large contingency of neuro-ophthalmologists who complete an ophthalmology residency, but then decide that they're not interested in pursuing surgery once they become a neuro-ophthalmologist. So there's really a diverse practice pattern that's already out there in the neuro-ophthalmology world. In terms of minor procedures, it's very common that folks will perform temporal artery biopsies or botulinum toxin injection. And in terms of botulinum toxin injection, that's also a procedure that's commonly performed by neurology-trained neuro-ophthalmologists as well. So a little bit about my surgical practice. I completed of course, medical training in neuro-ophthalmology, as well as my fellowship included complex adult strabismus surgery. And so in my first 3 years of practice outside of training, I had a low volume surgical practice that was a mix of cataracts and strabismus. And then I moved to a new location in Minnesota, and there was less need for cataract surgery. That sort of market was relatively saturated, but there was a large need for strabismus surgery. And so over time, my practice really evolved to being, by and large, a higher volume complex strabismus practice, with orthoptist support as well. So in terms of medical neuro-ophthalmology, there's going to be a very similar scope of practice between those who are neurology trained and ophthalmology trained. Typical referrals that we will see include vision loss of unclear cause. So someone, either an optometrist or an ophthalmologist, does an extensive eye examination, doesn't find a reason for vision loss, and then refers the patient on to neuro-ophthalmology. Double vision, strabismus, optic neuropathy, papilledema, central causes of vision loss, whether they be stroke or demyelinating lesions, and then of course, pupil abnormalities. History is paramount to the field of neuro-ophthalmology, and that's a little different than some of the other subspecialties within ophthalmology. And in fact, one of our very well regarded neuro-ophthalmologists, Alfredo Sadun, did a study where he found that chief complaint in history alone allowed him to accurately diagnose 90% of cases that came to his clinic. And then the exam added an additional 10%. So it just highlights how incredibly important history is in the field of neuro-ophthalmology. So with history, exam, and in-office testing such as visual fields, what we're trying to do is localize the problem that's causing the patient's vision disturbance. And once you find that problem, then you can order additional testing, whether that be an MRI, whether that be an ERG or an EMG. So the primary goal is to localize disease, which is much like neurology and a little bit different than most subspecialties in ophthalmology. So I'm going to just present one real life example. This is not a riveting case. This is just a bread and butter case of something we might see every day in neuro-ophthalmology. So a 57-year-old came in and he complained of gradual vision loss in the left more than right eye over the past year and a half. He underwent cataract extraction in the left eye, had no improvement in vision. And because his structural eye examination appeared normal, the referring provider is starting to think whether the patient might be non-organic. And so visual acuity loss was mild in the right eye and sort of moderate in the left eye. There was color vision impairment in both eyes. And then on pupil testing, there's a left afferent pupillary defect. So immediately when I see this patient, I know that this patient's not non-organic, or at least not exclusively non-organic, because there's a left afferent pupillary defect, clearly showing that there's a component of organic disease. But when you look at his fundus, you would say, yeah, those optic nerves look pretty normal. If you're looking carefully at that left eye, you might say, well, the fundus and the optic nerve look a little bit lighter, and that would be what we call pseudophakic pallor because this eye's had cataract surgery already. And really, the key to the diagnosis comes with the visual field test. So this is a form of visual field test called a Goldman, and you can see that there's these spots on the right side of the visual field. This is a right eye visual field, so on the right side would be the temporal visual field. And then if you look at the left eye, there are also spots or scotomas predominantly or exclusively on the left side or the temporal aspect of this visual field. So there is a bitemporal hemianopia. And immediately we order an MRI, which shows us our diagnosis. This is a pituitary adenoma with a classic mushroom appearance. We cannot see the chiasm here, but it must be compressed and leading to this vision loss. So this patient's not non-organic. And just for reference, this would be a normal MRI coronal section where we can see the optic chiasm and the normal pituitary. So we read about in books that the bitemporal hemianopia looks like this, dense, complete. And that's because of course, there's decussating fibers at the chiasm that come from the retinal ganglion cell axons from the nasal retina. And so those are more vulnerable to compression at the chiasm. But the reality is that the real chiasmal visual field defects that we often see in clinic might be, for instance, a nearly normal visual field in one eye and a temporal field defect in the other. or maybe global depression in one eye and a temporal visual field defect in the other. Or maybe it looks something like this, where it's sort of an incomplete bitemporal hemianopia. And so real life often looks different than textbooks. And this is part of the fun of being a neuro-ophthalmologist is identifying these subtleties. So why do I love neuro-ophthalmology? Well, it's a cerebral subspecialty, and it's, you're the Dr. House of the ophthalmology, I should say the Dr. House of the visual world. Hopefully people know what I'm talking about when I talk about Dr. House. So it's mostly referral based. Acute presentations are very common. You're going to see a lot of new patients. It's always interesting as the consultant. There are some types of patients that we will commonly follow long-term, including pseudotumor cerebri patients and ocular myasthenic patients. And of course, practice patterns are going to vary. So some providers will follow more types of pathology, but these are the patients that I typically follow long-term. I love that it's a mix of surgery and clinic for me, but of course, again, practice patterns are going to vary, and many neuro-ophthalmologists will have a pure medical practice, and it just depends upon the neuro-ophthalmologist. We're going to provide you exposure to a lot of different neuro-ophthalmologists and their practice patterns tonight. I like that there's a reinterpretation of neuroimaging with many patients that we see. It's very common for us to see patients that have already had MRIs of the brain that were read and interpreted as normal. And then we see the patient, we localize the disease so we know where the problem is, and we're able to go back and look at that MRI and say, you know what, it's actually not normal and the pathology is right there, and therefore your diagnosis is X. The neuro-ophthalmic diagnoses that we make often relate to vision and systemic health. So we are not just eyeball doctors. We make diagnoses that have relevance to the general neurologic health of the patient: multiple sclerosis, sarcoidosis, brain tumors. And so it's very, very important to the overall health of the patient that we make accurate diagnoses. And then it's a family business in neuro-ophthalmology. So you'll see just tonight that everyone gets along very well. It's a very, very cordial and collegial group throughout the country, throughout the world, really. So this is a picture from Julie, my co-moderator. She recently came up to Minnesota and gave a talk, and we had colleagues from Mayo, which is the other big institution in the state of Minnesota. And so we had a great time. And funny enough, this Julie and I were ice fishing when we came up with this idea for the webinar. So if you ever need to get creative, just schedule yourself an ice fishing trip, because there's nothing to do. You don't even catch fish out there, but you might get some creative ideas. So if you're considering neuro-ophthalmology, I would encourage you to talk to your local neuro-ophthalmologist. If you don't know who that is, feel free to shoot me an email or talk to any neuro-ophthalmologist, and I guarantee they'll point you in the right direction. If you have a chance, rotate with your local neuro-ophthalmologist. There's no better way to figure out what we do and to see whether you would be interested in a career in neuro-ophthalmology. And then attend the annual NANOS meeting. So I personally wasn't sure about what field I wanted to enter as a PGY 3 resident, and then I attended the NANOS meeting, and it was abundantly clear to me that neuro-ophthalmology was the right field for me. So I'd like to thank you for your attention, and we can already transition now over to our next segment of tonight's webinar. And I want to introduce our first speaker panelist, Dr. Bradley Katz. He's a professor of neurology and ophthalmology at the University of Utah. He is ophthalmology residency trained. He has, of course, a busy neuro-ophthalmology practice, but also has a comprehensive ophthalmology practice and performs a lot of cataract surgery as well. So welcome, Dr. Katz.
Thanks, Collin. It's a pleasure to be there with you all. And thanks, Julie, also for inviting me to be part of the panel. So, ophthalmology is kind of in its own little corner of medicine, like a lot of the things that we see every day, like cataracts, macular degeneration, glaucoma. Those things have, sometimes almost nothing to do with the systemic health of the patient. And a lot of times the care that we're delivering is sort of separate from the rest of medicine. And it's also like a lot of pattern recognition. So just like Collin was saying, where in Dr. Sadoun's practice, 90% of the time he can make the diagnosis based on the history. You're kind of taught that in medical school as well, that most of the time you should be able to talk to the patient and figure out what's wrong without even talking to them. Well, ophthalmology turns that on its head. I'd say 80 to 90% of the time you can tell what's wrong with the patient just by examining them. You could pretty much say, sit down and shut up, and you could examine the patient and and know, oh, you've got a cataract, oh, you've got macular degeneration, oh, you've got glaucoma, oh, you have a retinal detachment. You know, you can figure it out with the exam. And sometimes that's really fun and exciting. But for me, as Collin was saying, I really like the cognitive aspects of ophthalmology, and neuro-ophthalmology really does that. It's a lot of times the examination is normal. It's completely unhelpful when we're doing a neuro-ophthalmic exam, and we have to go back to the basics, back to the history and the chief complaint to make the diagnosis. And I find that's a lot of fun. And also, as Collin was alluding to, because of the systemic nature of many of the diseases that we diagnose and treat, we have to interface with other parts of medicine. So I'm constantly on the phone with radiology, neurosurgery, endocrinology, ear, nose, and throat. You know, I have all these other subspecialties that I have to work with in order to help get the best care for our patients. And I find that a lot of fun. Some of the diseases that we take care of in neuro-ophthalmology can be very time-consuming and stressful for both the patient and the physician, whereas comprehensive ophthalmology, which is where I spend half of my time, can be sometimes really easy, like taking care of cataracts and glaucoma and macular degeneration can oftentimes actually, frankly, over time get a little bit boring. And so by combining those two things, it's kind of fun. Like the neuro-ophthalmology keeps me interested and excited and engaged and working with colleagues. And the comprehensive ophthalmology is just quick and easy and simple. And, you know, I don't have to expend a lot of brain power. So for me, that's worked out to be a great combination. And I've continued to do cataract surgery throughout my career. And I still enjoy it very much. That's been, you know, it's the most commonly performed surgery in the United States, and it's constantly evolving. There's always new instruments, new machines, new technology, new lenses. And so it's always a challenge to keep up with the new technology. And I find that engaging and fun as well. I was asked to comment specifically about whether or not I was able to do surgical training during my fellowship. And I was, but it was really difficult because 1 year goes by quickly, and there's neuro-ophthalmology, there's a lot to learn. And so to try to squeeze in, you know, some surgery here and there when one of my mentors was out of town or there wasn't a clinic scheduled, picking up some time at the VA, you know, supervising the residents and stuff, doing cataract surgery. It was really catch as catch can. Some neuro-ophthalmology fellowships like ours at Utah is more organized. So if you do have an interest in doing surgery, you know, we can make that happen, but sometimes you have to make it up on your own. The other thing that I would say is that there's a big shortage of neuro-ophthalmologists right now. And so when I finished my fellowship, it was a little bit hard to find a job, but right now it's really easy to find a job. There are jobs everywhere because the demand is high, and the supply is you know, there's some of our neuro-ophthalmology colleagues are beginning to retire, and that's leaving big gaps all over the country. So you can kind of write your own ticket. If you really want to combine cataract surgery like me, or combine strabismus surgery like Dr. McClelland, or oculoplastics, or just you know, it's, you know, if your interests, you know, kind of bridge those different subspecialties, you can make it work. You just have to find a chairman or a clinic director who sees the value of neuro-ophthalmology and how you can free up the other clinicians to do what they do best by taking care of some of these difficult neuro-ophthalmology patients.
So Brad, just to go back to what you were saying earlier, you said that, you know, you didn't do a whole lot of cataract surgery during your fellowship. I didn't do any cataract surgery during my fellowship either. Was it challenging for you to go back to surgery after your fellowship? And what did you do to make it easier? What would be your advice if someone would like to do cataract surgery but doesn't do any during the fellowship? If you have any advice.
Yeah, no, that's super difficult because when you come out of residency, you know, depending on how busy you work cataract surgery wise, every week that goes by, you lose confidence in your surgical abilities, and that really hurts you. You know, to be out of the operating room for a whole year is really tough. But I was lucky that a lot of the cataract surgeons at my institution were very generous with their time. And so I would find a half a day that I could assist one of the other cataract surgeons and see their, and get back into the operating room. And sometimes they would assist me, so sometimes they would say, well, why don't you do this next case and I'll help you. And boy, I learned so much either during my fellowship or in the years following my fellowship to get myself back up to speed, get my confidence back up. So it's just a matter of finding people in your practice that are willing, if you do have to slow down during your fellowship year, there are definitely ways you can get back into the swing.
Brad, I imagine the time required to see a neuro-ophthalmology patient varies quite a bit from, an general ophthalmology patient. How do you keep your practices separate, or how do you account for that differential in time required?
Yeah, I'd say it's like 2 to 1. So on a neuro-ophthalmology day, I can see about 20 patients in a day, and on a comprehensive ophthalmology day, I can see about 40. And luckily, I have really good schedulers who know to put the neuro-ophthalmology complicated patients in the neuro-ophthalmology clinic and keep the general ophthalmology patients in the general clinic. Sometimes people leak, neuro-ophthalmology patients leak into my general clinic, and that can be frustrating for everybody, but it all works out. But having good schedulers, and you have to do some of the education of your schedulers to help them know what's a neuro-ophthalmic problem and what's not.
You mentioned earlier that, you as a neuro-ophthalmologist is also doing cataract surgery, that you've been kind of trying to keep up with the rapidly evolving premium intraocular lens. So, I think it's important to maybe talk a bit more about that, because I have the feeling it seems like a lot of, I think, ophthalmology resident may not be fully aware that you can do both and still be at, kind of on the, like putting a lot of those premium IOLs, even as a neuro-ophthalmologist. But so tell me a little bit more about this kind of the challenge to combine both. I think you briefly mentioned that it can be challenging to stay up to date with those kind of premium IOLs, but do you typically have to go to neuro-ophthalmology meeting and cataract meetings?
Yeah, so no, you're absolutely right, Julie. It is more challenging to keep up with both subspecialties. I do go to the neuro-ophthalmology meeting just about every year, and I occasionally go to cataract meetings. I usually kind of depend on my colleagues who are more full-time cataract surgeons to bring that knowledge home for me. And so I still, when I'm done in my OR, let's say I just have a half a day on a Tuesday morning, I'll wander into the room of the surgeon next door and I'll see what new instruments they're using or what new techniques they're using. And I'll ask them, hey, what are you doing for white cataracts? What are you doing for toric IOLs? What are you doing what's your favorite multifocal? So I tend to be a late adopter of new technologies. I tend to let my colleagues try that stuff out and see what really works before I'll bring it into my practice. And yeah, but you're absolutely right. It's challenging to keep up with both, but it's also fun to keep up with both.
That's great. Can we bring Vivek and Heather on? So I think we'd like to transition now. If we have any questions from the audience, this would be an opportune time. And if we don't, then I'd be very curious on Vivek. You're a surgeon as well. Maybe you can enlighten us in some of your experience as a surgical neuro-ophthalmologist.
Sure, I'd love to. There've been some good questions, so we can talk about that too. I had combined it with strabismus surgery, and I found that it fit well with my interest in eye movements. Actually, I arrived at neuro-ophthalmology through that side of it. I was more of an efferent interested person, and then the strabismus surgery was something that kind of meshed well with that. And as you learn more about the neurological pathways that control your eye movements, the strabismus side actually makes a lot of sense. So I focused that on mostly that. I wanted to do everything initially, cataracts, orbit, all that stuff, but it's totally impossible to be, really good at everything, I think. And then so you have to find what you really like in that way. But, I think so many people here, like Brad, does cataracts and does a great job because that's what he has focused his career on. And, you're a great strabismus surgeon. There are other people that do orbit. It's, I think, very hard to do everything. But that was my approach. I found what I loved the most, and I didn't spread myself too thin. I was able to kind of consolidate, and my clinic does overlap quite a bit and see afferent and efferent things together. So
we may have time for one question from the audience, if you or Heather can if you have a question for Brad.
Sure. I think the very first question is helpful, especially since you brought it up in your intro, Collin, which is all about sort of bread and butter. So how often do you end up seeing patients who have non-organic visual loss or functional neurological disorders? As much as I love everything else, this is a big drawback for me. So Vivek and I felt that it wasn't super common, but interested in your feelings. And my addition was I've actually come to quite like it, even though I started off in a similar place as this questioner.
Go ahead, Brad, you take that one.
Oh yeah, no, I agree with Heather 100%. Sorry, Heather 100%. Like I found non-organic vision loss very frustrating at the beginning of my career. It was it could just kill your clinic. But now I'm fascinated by it. And I don't get frustrated by it either, because non-organic vision loss is just as real as organic vision loss. It deserves just as much time, care, and attention as multiple sclerosis or a traumatic brain injury or Parkinson's disease or any of the other horrible things that we sometimes see. And so yeah, I've learned, I wouldn't say love it is a strong word, but fascinated by it and not afraid to treat it.
Thank you so much, Brad. I think we're going to move to our next speaker, and we'll come. Brad, you'll join us at the end for the group discussion. So our next speaker is Dr. Fiona Costello, neurologist and professor in the departments of clinical neuroscience and ophthalmology at the University of Calgary in Alberta. And if we can just bring Fiona with us.
I'm here, Julie.
Perfect.
I'll go on record saying I don't share the deep, passionate love for functional vision loss that Heather and Brad are afflicted by. But thank God they do.
So Fiona, I've known you for a really long time, and I realized that the one thing that I guess never really asked you is how and when, as a neurologist or neurology resident, I should say, or maybe medical student, did you become interested in neuro-ophthalmology?
All right. I didn't even know what neuro-ophthalmology was, probably until my 4th year of residency. I'm neurology trained. So I think I became interested in it for all the right reasons and maybe all the wrong reasons, in that it was the area that most sort of frightened my mentors, and they didn't scare easily. And so I maybe was unaware of it when I was a more junior resident, but that's what got me interested. So I basically said, I can spend my entire career running from this, or I can literally run towards the fire and see what this is about. So I would definitely say an R4.
Fiona, so I'm curious, what I often hear from neurology trained folks is that there's not a lot of exposure in many places to neuro-ophthalmology. So a lot of neurology residents don't really know what neuro-ophthalmology is. Do you have any advice for neurology residents who may not have a rotation at their center, at their residency? How do you get to know neuro-ophthalmology?
No, I think that's amazing as a question. Like, I will say that it's completely normal and 100% okay to feel daunted by ophthalmology, to not have done neuro-ophthalmology. I didn't have any rotation in ophthalmology or neurology before I chose the specialty. I hadn't even had an eye exam. I would say, and Julie is going to be my kind of silent witness to this, I think it made me insightfully weak to start, but that wasn't a barrier to me eventually, I think, doing fine. Like, we all can't really we can't have much control about where we start with a challenge. We just can challenge ourselves to finish it on our own terms. And so for me, not having done ophthalmology, neuro-ophthalmology, having very little sort of introduction to the craft was not a problem. Something, as long as you acknowledge it, you just have to build in contingencies for. So one thing I think was really important for me is that I had Chuck Maxner, who was in a neighboring province. There was no neuro-ophthalmologist in the province that I trained in, ergo my lack of experience. But he really inspired me as someone who spoke so passionately and with such love about what he did. So I think that's something for all of us to remember, that, you know, if you bring great energy to what you do, other people are intrigued to know what that is. So I really do feel I owe Chuck that. And for me, I actually very, very consciously sought to do an extra year of fellowship, recognizing that I was neuro trained and I wanted to be very uncomfortable. I wanted to be very comfortable and no longer be uncomfortable with, you know, the ophthalmic aspects of the discipline.
Fiona, along with your neuro expertise, you have developed over the years pretty amazing expertise also in the field of neuroimmunology and multiple sclerosis. So it seems like you can actually combine two subspecialty of neurology. Can you please maybe tell us a little bit more about this dual expertise that you have developed? And also, how do you divide your time between neurology and neuro-ophthalmology?
I think that's fair. I think because I wasn't afraid of what I didn't know, which was a lot, starting my fellowship, it's really helped inform decisions for the rest of my career. So I actually really loved multiple sclerosis and neuroimmunology was less well characterized back in the day. You know, I mean, I was a fellow. I finished my residency training in 2000, so that's a long time ago. But I did love the discipline, and I always wanted to use neuro-ophthalmology to better understand core neurological diagnoses that I would be treating. So that I worked in an MS clinic. I did general neurology. I still do lots of ward neurology, and I do general neurology on call. And I always knew that would be kind of my cross to bear. So I needed to have enough tools in the box to be as effective as I could possibly be at those different disciplines. I would say the key to my accidental success would be really immersing yourself in something. So the same principles that made me choose to do 2 years of neuro-ophthalmology have really helped me, because I go to MS meetings, I go to, general neurology meetings, I keep up with the literature. You have to kind of always be at the forefront of what's happening, a little bit like Brad said. Like, you can choose all sorts of ways to get there, but you have to be in the thick of the conversation to stay current in your knowledge. And for me personally, having those extra challenges kind of keeps me on my toes, because my Achilles heel as a person and as a professional is boredom. And so I do really like the perspectives that I get. I love the perspectives that neuro-ophthalmology brings to my understanding of MS, but I also love the things I learned from those disciplines that I bring back to neuro-ophthalmology.
That's great. So Fiona, you've really very successfully combined neuroimmunology, MS, and neuro-ophthalmology. Maybe there's residents out there in neurology who are considering, maybe I could combine neuro-ophthalmology with other subspecialties in neurology. You know, what are the other subspecialties that you think combine well, and maybe there's already someone out there doing it?
Okay, everything. So my residents hate hearing me say this, but I think that pretty much every neurological condition can be best understood through the visual system. And I drive them crazy when I say this, but honestly, when I'm on the wards, and not just neurology, when I'm on the wards, my sort of comfort with neuro-ophthalmology means that I actually can better understand all the consults on oncology, neurosurgery, internal medicine. Within neurology as a whole, the subspecialties of, for example, stroke, neuroimmunology, even movement disorders, there are so important key aspects of those exams that can really localize the problem and shed important kind of information about what's going on. That, for me personally, I think neuro-ophthalmology makes everything brighter. And I think you can invent the person that you want to be. You can be my good friend and colleague Suresh is a strokeologist who does neuro-ophthalmology. But we know loads of folks who do neuro-ophthalmology, for example, with MS, with neuroimmunology, with headache. So really the sky's the limit. I would just say to anybody coming up through the ranks, don't feel like you're going to be in a box or that there's a formula that you have to fit into. You can combine neuro-ophthalmology with anything.
That's a great answer, and I think I would agree with that too. We're going to bring Vivek and Heather back with us, so hopefully they can bring us some good questions from the audience.
Hi, Heather. We've been madly chatting. I mean, I'm a terrible typer, so I've been trying to type. So if there's typos, it's just I'm trying to type fast. But Heather, there's been some good ones, right? I think one of the things that I thought was good was this one here. Did you feel like you had to give up other aspects of medicine to be, so specialized in neuro-ophthalmology? I think some people wonder about that, right? And I think we answered it similarly, and that it actually is something that opens the door to many other fields. I mean, you have to keep up and you have to learn a lot about other fields. And the visual system, as Fiona mentioned, does open the door to understanding many other disorders, whether it's medical, neurological, neurosurgical. And having your own, sort of niche is nice because you understand the visual system better and almost everything else connects to that. So you do have insights that others may not have. So I feel like it's actually allowed me to stay more of a quote unquote doctor than I maybe would have if I had not chosen something that had to interact with other specialties. Does anyone else feel that way or more?
Fiona, if just something came to mind, you kind of briefly mentioned that earlier, I think when you answered the first question, but just to go back a little bit to what you said earlier, there are definitely some students who may be considering neurology versus ophthalmology residency with the ultimate goal to become a neuro-ophthalmologist. Are there any specific advice you can give them on how to choose?
I tell people, I'm sure we all, get contacted by medical students expressing interest in neuro-ophthalmology. And the first thing that I tell medical students is, let yourself breathe a little bit, like get to know yourself. What you think you know about medicine and what you might like, if you really immerse yourself in the learning experience, could easily change. I would say ophthalmology and neurology, they're very different worlds. I mean, one thing I love about what I do is interacting regularly with surgeons who think very differently than me, seeing how incisively they break problems down, learning pattern recognition and how it informs high volume, quick decision making. Those are not natural skills of mine. So I have a lot of respect and reverence for people who can work like that. If you're a person who wants to be surgical, mostly I think in ambulatory clinic settings, if you don't mind the business aspect of a practice, if you are not someone who wants to spend a long time, weaving through the murky waters of the history, ophthalmology might be a discipline that's calling your name. As a neurologist, I would say it's really core to my being. Like, I like connecting with people. I think it took me a while to figure out that I also really like high acuity. If there's a diagnosis on the name of my clinic, a little part of my soul already dies. So you have to think about that. Like, if you're in a glaucoma clinic or the MS clinic, chances are pretty high you're going to see glaucoma or MS patients. Am I right? And if that's for you, if you like the sort of the predictability of that existence, I think it's really, really important to consider and ask about who you are as a person. For me, I like the diagnostic thrill of the chase. I love not knowing things. I love that in neuro-ophthalmology, I will still see something for the first time. And it'll make me tear my hair out because it's a nebuloma wrapped in a mystery, deep fried in a riddle. Like, I love, love, love that. But that's not for everybody. So if you love those things and you love actually talking to people who love those things, then neuro-ophthalmology is exactly what you should consider. And the route doesn't really matter. The journey will just make you better. And you can think about who you are as a person. And if you want to do surgery, for example, or if you want to do other aspects of neuro. But if that is what drives you, then I think it's a perfect plan for anybody who has interest in pursuing the fellowship.
Thank you, Fiona. That's a wonderful answer. We are actually going to move to our next speaker. We will bring you back at the end. I would like to introduce now Dr. Sang Hong. who is an ophthalmologist who completed a fellowship in neuro-ophthalmology as well as a 2-year oculoplastic fellowship. He practices both neuro-ophthalmology and oculoplastics at the Medical College of Wisconsin. And so we're going to please bring Dr. Hong with us.
Hi, and thank you. Thank you for inviting me to be on this panel. It's a great group. I'm excited to be here and share my enthusiasm for being a surgical neuro-ophthalmologist, which I love being. I can't think of doing anything else with my career.
Our first question for you, Sang, is what led you to pursue 2 fellowships, a dual fellowship?
That's a very good question. It's a little complicated, but I'll try to keep it short. I knew from early on in my career, like I loved anatomy and dissecting. Anatomy lab was like one of my favorite things, and so I knew I wanted to be a surgeon, and I knew also that I was like very OCD and very meticulous, and so I wasn't going to be like one of those like slash and burn, like, you know, like general surgeons, but I'm going to be doing something like really microscopic and meticulous and careful. And so I actually initially did ENT for a little bit, and then before switching into ophthalmology. And when I switched into ophthalmology, I thought, oh, you know, retina sounded really cool, and you know, making the blind see and all that. And but with my ENT background, when I did my oculoplastics rotation, my oculoplastics attending was like, wow, you really know how to, you know, do these handle tissue really well. And I mean, I know, you know, I've had ENT background, so that was a natural thing. And so I gravitated towards oculoplastics. And then when I did my neuro rotation and spent more time with our neuro-ophthalmologists in my residency, I really loved all the really cool, challenging, exciting cases. I mean, it seemed like all the cool cases that got discussed in grand rounds were mostly these neuro-ophthalmology cases. And so I was like, wow, that's really exciting. But I wanted to be a surgeon. So I thought, well, it seemed like I couldn't do surgery. I didn't know I could be a surgical neuro-ophthalmologist. And then so I did oculoplastics. And then I wanted to do more orbit. And then so I sought out like a orbital surgical fellowship and found out about Jack Kennardell and Kim Cockram's fellowship in Pittsburgh, and that is a surgical neuro-ophthalmology fellowship, and that's where I got to be a neuro-ophthalmologist and a surgical neuro-ophthalmologist, and got just amazing training, which was very empowering and yet also very humbling. As neuro-ophthalmologists, you're as much as we're relied on by other specialists to kind of be the buck stops here to figure things out when they can't figure it out, to take the time and unravel the mystery and say, duh, this is what it is. But there are times I don't know what's going on, and it's very humbling, and yet also very very exciting to constantly be learning. And that's why I make it a priority to really go to Nanos meetings like every year, and really try to stay on top of the state of the art in neuro-ophthalmology. And it's I think we're always learning. We're lifelong learners.
So you sort of alluded to some of the things that I was wondering. I've always been amazed, saying it, how effective you are at staying involved both in Nanos and I think in ASOPers as well. I believe that you're the fellowship director for your oculoplastics fellowship. Is that right?
Oh, I'm not the director, but I'm just one of the preceptors.
Okay, gotcha. I know that we had talked
Yeah.
about applicants in the past. But is that challenging for you to continue to stay active in two worlds? There is a trend. Sometimes people who are dual specialty trained will tend to drift, towards one specialty or the other, but you've maintained yourself very active in both. Tell me about other ways that you sort of achieve that.
So you're right, Collin. I would say a lot of my, colleagues who've done both neuro-ophthalmology and plastics, a good majority of them, I'd say, end up drifting more towards plastics. I think just the economics of reimbursement and whatnot. That's probably what's driving that. But so what I do is I carve out time. So for me, Tuesday is my neuro day, and so I jealously kind of guard that, and I try to actively participate in the call schedule and all that. So it does take effort, but I think it's well worth it. I really do enjoy both aspects of what I do, and but it does take good effort to do that.
Well, Fiona mentioned that any subspecialty of neuro-op can be combined with neurology. But she talked about we know that their fellowship when people do headache and neurology and neuro-ophthalmology and neuro-ophthalmology and neuroimmunology. So can you mention a little bit more of any other ophthalmology subspecialties? We talked about oculoplastic and neuro-op, but what about any other subspecialties of ophthalmology that can be combined with neuro?
Oh, sure. I think many of them can be. I think some of the more popular ones would be oculoplastics, and then also strabismus, like Collin does. I think medical retina also would be another one that would blend well with neuro-ophthalmology, and possibly even uveitis. Although I think that would, uveitis is like another really time-consuming, some ways very exhausting, like specialty. I don't know if you combine neuro-op and uveitis, that might be a recipe for burnout. If you're not careful, but I suppose you could. But yeah, I think cataracts. You could combine pretty much anything, I think.
That's great. I agree. Heather, Vivek, can we bring you guys back on? Do we have any burning questions from the audience for Sang?
One question I thought was really interesting. It was asked from the neurology perspective, but I'll ask Sang as an ophthalmologist. Is this fear of being in a multidisciplinary specialty and therefore missing something acute in the other specialty? So this one's about a neurologist missing an acute eye issue. So how, as an ophthalmologist, have you ever been afraid that you're going to miss the acute neurological issue or earlier in your training, and how have you approached that?
Sure. Yeah, of course. Especially early on, but even now, and that's why I think keeping on top of the information, the latest information by attending meetings, being just jealously guarding that time to learn, keep learning, and I'm lucky to be practicing with 3 other medical neuro-ophthalmologists, and so we were able to divide up the work. I'm not stuck with seeing all the neuro-ophthalmic patients, for example. I wouldn't be able to do as much of the surgeries if that were the case, and also relying on their expertise when needed. So I'm certainly humble enough to do that, and because I don't know everything, and I think the strategy would be, as much as possible, to keep learning by availing yourself of all the learning opportunities by attending meetings and whatnot, and also relying on your colleagues and the different subspecialties.
Thank you so much, Sang. We're going to move to our next speaker, and we'll bring you back at the end for the group discussion. Really appreciate your feedback.
Thank you.
Our next speaker is Dr. Shannon Barris. Shannon is a pediatric neurologist and clinical associate professor of ophthalmology, neurology, and neurological science at Stanford University. So we'd like to bring Shannon with us and find out more about getting to Neuro-Op as a pediatric neurologist.
Well, thank you. Thank you for having me here today.
So I guess first question is pretty much what I was just saying just a few seconds ago, but as a pediatric neurology resident, how did you find the field of neuro-ophthalmology, and what led you to decide on a neuro-op career?
It was completely by accident, but probably the blessing of my life. So similar to Fiona, I just fell into pediatric neuro-ophthalmology. I really did not have any exposure to pediatric neuro-ophthalmology. What happened was I was a pediatric resident. I'd always wanted to go in and work with children with disabilities. That was my focus prior to medical school, my focus during medical school, and then what brought me to a child neurology residency. And I ended up having 2 children during residency, and I was working both as a mom and doing residency. And it was very challenging with some of the pediatric patients. And I think the moment happened where I was doing a ophthalmology rotation so I could get better at looking at the back of the eye, because like Fiona said, I was scared of that. I knew I wasn't good at looking at the back of the eye. So I just took the bull by the horns and said, I'm going to be in ophthalmology for 2 weeks. And my whole goal is to look at the back of the eye. When I was in ophthalmology for that subspecialty rotation as a child neurologist, I had this sort of sinking moment of, oh my gosh, this is the most beautiful exam. I loved the patients that I was working with because they were the exact complicated child neurology patients that I wanted to work with, but I only had to answer the eye question. And that was so freeing to me that I didn't have to go over the ADHD medications. I didn't have to discuss the headaches. I didn't have to talk about the IEP. And I had a moment where I thought I actually chose the wrong residency, and I wanted to go repeat and do an ophthalmology residency. Until the next day I came back and told the attending I was working with, I said, I honestly feel like I'm in the wrong residency. Like, I want to see a lot of patients in a day. I want to see these types of patients, but only answer certain questions. And child neurology was just there was just so much to answer in one small 30-minute visit. And they're like, well, why don't you go into neuro-ophthalmology? I don't know what you're talking about. I've never heard of that. So I looked online. I was like skipping on my way home, and I Googled neuro-ophthalmology when I got home. And it's kind of, at the time, it was a rolling fellowship. And there was an interview, like they were saying, I emailed one of the fellowship the fellowships, and they said, yep, we're interviewing, we'll be choosing in the next 2 weeks. And I went, oh my gosh, I don't even know what this fellowship is, but I'll come. So I flew out to Philadelphia about 2 weeks after I ever heard what this fellowship was. And I remember standing there and then being like, well, why are you interested? I don't know, I learned about this 2 weeks ago. And I think it was my enthusiasm over this new career, my enthusiasm over these types of patients and the diseases that they worked with, which sort of led me to getting the fellowship. And I remember even going off to fellowship because I got it 2 years before I was actually my 4th year of residency, which was I had 2 more years of child neuro to do. And people would be like, I'm sorry, what are you going into? I'm like, I don't know. I honestly don't know what I've signed up for, but I'm doing it. And it was the best thing. It was absolutely pulled me away from what I didn't want to do and originally thought I had wanted. So like Fiona had said, there's some things that you get stuck in that you want as a resident, but then once you start working with it and once you start realizing what the day-to-day looks like, sometimes you don't want that. And that's what happened to me.
What a fortuitous discovery of neuro-ophthalmology. That's amazing.
So I discovered it and got a fellowship in 2 weeks.
That's efficiency.
And I love my job. It's the best job I've ever had. I recommend it to anybody and everybody. So
for the children neurology residents who may be listening, how would you advise them? Maybe they're concerned that there's not going to be many of those 35 AUPO certified fellowships in ophthalmology that they could go to. How can they learn more about the various fellowships, and what did you look for? What would you look for in a fellowship if you were a child neurology resident?
Absolutely. So because I was child neuro, the only places I looked, when I went and looked that night, I came home, I looked at all the different fellowships. The ones that I knew had very strong child neurology residencies were the ones I looked at. And there was only a few on the list at the time. I would say that nearly every program sees children. There is so few pediatric neuro-ophthalmologists that all children do get funneled through the adult neuro-ophthalmology groups, regardless of where you are. So no matter which fellowship you choose, you will be seeing children. Maybe to the chagrin of the attendings, but you will be seeing children no matter what. So you will get training. However, there are places that you can go where they have a higher volume of children, especially ones who have pediatric neuro-ophthalmologists. And there's at least 6 to 10 places now that have a very strong and robust pediatric neuro-ophthalmology practice where you will get training. It's not specifically a fellowship, but it is one where at least half the time you probably can be seeing children. So the choices are more than they were 10 years ago when I was looking, but I would definitely look to the programs that have a higher volume of pediatric neuro-ophthalmology.
So Shannon, in your practice, are there enough pediatric cases to fill your entire schedule, or do you have to see adult neuro-ophthalmology?
Yeah, so if you would have asked me that question back when I was trying to get my first job, I would have said that I will have to split my time between adults and pediatrics, because I will never be able to fill a whole career out of pediatric neuro-ophthalmology. But as one of my chairmen said when I first got here, is if you build it, they will come. And that has so been the case, that as you build it, the more and more people keep coming. And I now have a 6-month wait in pediatric neuro-ophthalmology, and I see pediatrics about 3 days a week. So I could absolutely see children 5 days a week if I needed to. And I know my colleagues over at Boston Children's and Emory and down at CHLA, UCLA, I think they too could probably fill an entire clinic a week. The question is, do you want to? So what I love about neuro-ophthalmology was the breadth of the patients. I really enjoy the adult aspect, and I enjoy seeing kids, and I like going between both of them. So I currently do see both children and adults about equally, but that's by choice. So I do think you could probably fill at least 4 days of clinic with pediatric neuro-ophthalmology. I'm just not sure if it's up to you, if that's what you'd want to do. I think it's an option for you for sure.
Thank you. We're going to bring back Vivek and Heather. Any good questions out there from the audience, or do you have questions for Shannon?
Well, I work with Shannon every day. So she gets all my questions already. One question that came up. So as neurologists, we train in pediatric neurology or neurology at the outset, but in ophthalmology, pediatric ophthalmology is a separate subspecialty. And the question was, could an ophthalmology trained resident do neuro-ophthalmology and plan to do pediatric neuro-ophthalmology without doing a peds opt fellowship?
Yeah, I saw the question come through. I think that would be pretty challenging if you were ophthalmology, not having a significant amount of pediatric training, because so much of my pediatric neuro-ophthalmology is really part of the exam and understanding children and knowing what the developmental stages of children should be. And to be honest, examining the patient is half the battle. So, which to me is the most rewarding part, is seeing a challenge ahead of me and actually getting the exam done on a patient that is screaming or, 2 weeks old. To me is actually what I enjoy and is rewarding for my job. But I don't think you would get that kind of training if you just did ophthalmology. I do think a pediatric ophthalmology fellowship would be needed in addition to to a neuro-ophthalmology fellowship.
Thank you, Shannon. We're going to now move to our next speaker. We'll bring you back at the end. And our next speaker is Dr. Jane Bailey, who's an ophthalmologist who works for a nonprofit health system in Minnesota. She does a mix of neuro-ophthalmology, comprehensive ophthalmology, including surgery, as well as administrative leadership.
Hi.
Hi, Jane. Welcome.
Oh, thank you. There's nothing I would rather do than talk about why I'm doing neuro-ophthalmology and what a great career it is, like everybody else before me has said.
You have a really unusual path to neuro-ophthalmology. And that's, I think, what I would like to ask you first. You practiced as a comprehensive ophthalmologist for about 20 years, and then you decided to do a neuro-op fellowship. Can you, and you work in private practice also. So just tell us a little bit about what led you to make that decision.
Yeah, I mean, temporary insanity for sure. Don't try this at home. I did my residency a very long time ago, and then I did an extra 6 months where I did peds and plastics. And I really loved neuro-ophthalmology with Stan Thompson and Randy Carden when I was a resident, but it didn't really occur to me. I was going into the Air Force, and I knew I had to do everything, and I was particularly worried about doing a lot of peds and plastics, I guess. And so I went on to kind of do everything. And then as your career goes on and you get busier, you sort of, as one of the earlier speakers said, you sort of narrow it down to things that, you're interested in and you can be good at. And after 20 years of that, and Fiona mentioned this, I was bored, honestly. And comprehensive ophthalmology is great, but it's generally management decision-making, and it's very rapid fire, and it can be very repetitive. You can hear yourself saying the same things over and over again. And I knew as I was sitting down with my kids who were teenagers, and they were talking about what they wanted to do in life and what they wanted to be in life and these challenging things. And I thought, oh, no fair, no fair, no fair. I want to do that. I want to have interesting challenges. I want to learn something new every day. And I want to have this community, this tight-knit community that supports me when I have challenges. And don't get me wrong, I had great partners in my private practice, but mainly I spent time with my techs and the patients. And I didn't interact there. I didn't feel like there was a community. And so not to go on and on, but now I have all that. I have everything I ever wanted, everything I ever dreamed of. Super challenging. But I learned something new absolutely every day. And the whole nanos and neuro-ophthalmology community is so committed to solving these riddles and taking care of patients that they're excited if you ask them a question. They are excited if you ask a colleague for help, and they'll do everything they can. And they all get stumped a lot too, as Dr. Hong mentioned. So we're all in it together. It's really nice.
Jane, speaking of everything you've ever dreamed of, when you went to fellowship, I'm sure you had something in mind, a career that you envisioned in neuro-ophthalmology, combining it with comprehensive, and then you get out in the workforce. Has it been as you envisioned? What have been some of the surprises or that you maybe didn't envision?
Well, I have a tendency to leap first and think later. And so then you learn things the hard way. And the things I learned the hard way are that if there are, as someone else mentioned, there are so many jobs in neuro-ophthalmology because other people, particularly comprehensive ophthalmologists, don't want to deal with these patients. They're very complex and it's difficult and they take a lot of time, which is great for us. However, if you are looking at a neuro-ophthalmology job, but they don't, as someone else mentioned, value you and support you, and you don't have the ability to triage the types of patients that you're seeing so that they're appropriate for your level of training and your skills, and you don't have the support in terms of technicians, testing, people who can do your phone calls and find the records and do those things, so you're not dying from the administrative burden that exists in taking care of complex patients, then that's not the right job for you. And you believe me, there are lots of jobs where you will be valued and you will have that support. And that's, I think, what avoids burnout and keeps it fun. And there's such a huge access to care problem in neuro-ophthalmology. And that's what helps with the access to care too, if you have good support. So that's just, one thing I would say is I did find a place like that, but it wasn't my first try.
Jane, the other thing that's unusual, it's you've got a lot of very interesting leadership experiences, and one of them was actually you served as a board director for the the American Board of Ophthalmology, and you did so before you became an ophthalmologist, if I'm correct. So, do you find that your training as an ophthalmologist somehow helps you in your role on the board? Because part of your time on the board was before neuro and then after. Do you feel like that extra expertise added something to your leadership role?
Yeah, that's a fun question considering you took my place, Dr. Keller. And I actually finished my chair year in 2022, and now I have all this found time. So life is good, although that was a great experience. But I think that I felt like my biggest asset to the board was to be a comprehensive private practice ophthalmologist, because even though that represents the majority of ophthalmologists in our specialty, it tends to be a very small minority on the board. And then during my time on the board, I went to, a large university academic practice and trained in neuro-ophthalmology. And that gave me, I felt like, two different perspectives of all the different stressors that are on people at different points in their career, and then as they choose different pathways. And so I think it's valuable from that standpoint. The other thing I'll say about neuro-ophthalmologists is that when you're in a room full of people, you can always predict what the neuro-ophthalmologists are going to say to any situation. They're going to say, I wonder how that happened. I wonder, they want to know what the mechanism is. And it's actually can be a little annoying, but it's very valuable, because other people are just like, well, this happened, let's do this, and the neuro-ophthalmologists are going, yeah, but wait a minute, now why did that happen? How did that happen? What's the mechanism for that?
So Jane, I think there's probably people out there who are envisioning, maybe I'm going to combine a career in neuro-ophthalmology and comprehensive ophthalmology. For those people, how would you suggest structuring your practice? What percentage do you need to be neuro-ophthalmology to remain sort of competent as a neuro-ophthalmologist, but maybe still competent as a cataract surgeon? How do you break down the time? How would you advise people?
Well, that's a great question. And I think it's probably quite personal, but I think for a lot of people, neuro-ophthalmology is very intense. There's a lot of follow-up. I don't think a lot of people have a neuro-ophthalmology clinic 5 days a week. In fact, I don't know anybody who does that, and it would be pretty hard. And so I think I do neuro-ophthalmology 2 long days a week. I occasionally throw an extra half day in there, and then I triage 3 days a week. So I'm kind of in it one other day. And then I do comprehensive a day and a half a week, and I have an OR day. And then the rest of it's administrative time, I guess. I don't know that there's any time left if you do the math, but I would say you can't do so little of one thing that you can't see the follow-ups in a reasonable time. You can't stay sort of connected to the practice. So you have to keep that in mind. And then the other thing I would say about comprehensive, as someone who tried to, somebody else mentioned this, tried to do it all, for a while, is you can't, so don't try, but pick the things that you enjoy and that you're good at. And I think for me right now, I do a lot of lid surgery, and it's a great blend with neuro-ophthalmology, because that's where in my, ptosis and dermatochalasis clinic is where I find all the myasthenia patients and the Horner patients that just sort of got, shuffled over there and things like that. And also I find that glaucoma is a really great, sort of blend. It's just another optic neuropathy, and there's just a lot of nice overlap there, but it's not as intense. And so I think you can, if you're lucky, you can structure it any way you like. I personally like to keep the two, comprehensive and neuro, as separate as I can, although I have emergency slots in comprehensive and they throw anything in there, which is true of my patients or my partners as well. But I do know other people who just blend them in during the day, and I don't know how they do that, but I think there's a lot of right answers.
So we're going to ask Vivek or Heather any good question that we're getting from the audience for Jane.
Heather, I don't know if I saw one specifically for Jane. They're kind of just filing in. We're busy typing, but I think Jane's talking about a lot of the similar trends that we have, like really mixing things. Like how do you kind of combine, whether it's a combination of administrative stuff and so forth. I actually like this one question that I maybe bring it out there, because the elephant in the room is income, revenue, paying. I mean, somebody wanted to know about like how does a neuro-ophthalmologist make a living? Like, are they comparable with other people?
Let's bring this for the group panel, Vivek. I think it's a really good one for the entire group.
Okay, good. I think it's something that we never talk about, but it is on people's minds.
Absolutely.
One question that came up that you might have some insight on is, was a resident noticing that when they were on neuro-op, they as a neurologist took a lot longer than an ophthalmologist did. And if you have sort of thoughts on time spent with patients, so I'm interested for you running an ophthalmology-based practice, do you see patients as rapidly as your retina colleagues? Is that an issue?
You mean in comprehensive clinic?
No, in your neuro clinic.
Oh no! Have you seen the retina clinic? It's woo. No, I mean it just is. Brad mentioned this, and I kind of joke around that my comprehensive practice finances my neuro-ophthalmology habit, but there's no possible way to have that kind of throughput, and that's why you need a lot of support, so that you are spending your time taking that history and really making the diagnosis and interpreting the test, and not all that other kind of administrative stuff that isn't a great use of your time. And there's no question that it doesn't pay as well as if you're a high volume surgeon or something like that. But I do think that you can bill for your time. Your time is really valuable, and for me, I would not be doing ophthalmology anymore if I hadn't done the neuro-op fellowship, to be honest, because I was burnt out. I would put my head on my steering wheel in the morning before I had to go into my clinic and see 45 patients with dry eyes and cataracts, and just think, oh, come on, you can do it. Just get out of the car and do it. And now I just can't wait to get to work. I get there early to look in my inbox.
Thank you so much, Jane. Fiona, hold that question. We just have one quick presentation, and then you will be, we'll ask you to go ahead and make your comment or your question when we all get together. So we're just going to move on to Dr. Amy Zuka, who's a neurologist and an assistant professor of neurology at Rush University Medical Center in Chicago. And Amy will talk about, okay, now that you're all interested in neuro-ophthalmology, how do you go from here?
Thank you so much for that wonderful introduction. So I want to talk with you a little bit about kind of the resources that are available to learn more about neuro-ophthalmology as you kind of think through everything that you've been hearing this evening. So we'll start off with first, the most important resource I think you can find out there is through our National Society NANOS, which is the North American Neuro-Ophthalmology Society, has an excellent webpage you can find at nanosweb.org. And on that page, you'll find a gateway to a lot of very important things. So first and foremost, there's an excellent webpage that you can access right off. It's actually in the top of the webpage, and that's to the YONO portal. YONO stands for Young Neuro-Ophthalmology. And it has so many really important resources. The QR code over here will take you to the YONO portal as well. And from there, you can find all sorts of great resources. You can link to our novel, which is a resource put together. It's a virtual library of neuro-ophthalmology resources. It has textbooks. It has interesting cases. It has just really a mountain of knowledge regarding neuro-ophthalmology, and it can be a great place to start if you're looking for resources for a project, to learn more about a patient. And we really encourage you to use that free resource. We have some social media platform availability. We're on Instagram, we're on Twitter. Under @Nanos Neuro-Op and Novel Nanos for Instagram, and then Nanos Tweets for Twitter. So make sure to take a moment and follow us there. There are lots of opportunities for mentorship, and we'll talk about some specific ways to reach out for mentorship from here. And then there is a trainee listserv through Nanos. And this is a listserv that's targeted towards medical students, residents, and fellows who have an interest in neuro-ophthalmology. It's a low pressure way to learn more about our field, to ask questions about applying for fellowship, becoming a neuro-ophthalmologist, working in different environments. Can be helpful for finding research or mentorship opportunities. And through this listserv, we're sending out content occasionally about the field, but it's a great opportunity to just post questions. You can email info@nanosweb.org to join, and I hope that all of you will take a moment to do that. Another really wonderful resource that you can find actually through the Yono page are our upfront cases. These are, that stands for Unknown Patients for Residents in Ophthalmology or Neurology Training. And these are, if you like the case that Collin presented earlier today, that kind of just illustrated some bread and butter cases, this is another great example. These are all great examples of kind of what we're seeing on a regular basis, talking about kind of the clinical reasoning, the imaging findings, and putting it all together in a really nice case that illustrates things. So take a moment to look at that. That's also the QR code to go to the upfront cases. And then finally, another really helpful resource is a podcast that actually was just kind of launched by Dr. Orefe Adesina, and it's called Out of the Blind Spot. And the first 2 episodes were about the neuro-ophthalmology pipeline. It featured myself and my co-chair, the pipeline co-chair, talking about the neuro-ophthalmology pipeline. And then episodes 3 and 4 on the value of neuro-ophthalmology, and it's a deep dive into why neuro-ophthalmology is so important as a specialty. And I really strongly recommend that you check these out. They're available anywhere where you can get your podcasts. And then finally, attend a Nanos meeting. If you have the chance, it's a great way, as everyone has mentioned already, to meet others, to really become a part of the community, and to learn more about neuro-ophthalmology. Our meeting this year is March 2nd through 7th and is in Honolulu. So if you can find the time and the means to get there, I would strongly recommend joining us. All right, so a couple just pointers for everyone, hopefully at whatever stage you happen to be in. So as a medical student, my recommendation, if you're interested in neuro-ophthalmology, seek out opportunities to participate in neuro-ophthalmology at your home institution. Meet your local neuro-ophthalmologist, consider some research opportunities with them or with your ophthalmology or neurology colleagues, and then take the time during this period to decide about ophthalmology versus neurology residency based on all the different pieces of that and the different considerations that were mentioned earlier in our webinar today. Consider doing some elective experiences, particularly during your M4 year. So if your institution has a neuro-ophthalmologist, they may have an elective already, or they may have the opportunity to create your own elective. So another option is to do away electives at other institutions. So if you're a medical student, you're familiar probably with VSAS, which is the AAMC application service for away electives. And there are some dedicated neuro-op electives, and I know that there are more in the works. And many institutions offer some customization for their neurology or ophthalmology away electives, so make sure to pursue that. And then as you're going through all these experiences, start thinking ahead about your residency programs, where you want to be, what kind of program you're looking for. There's a lot of different things to consider as you're looking at all the different options out there. For residents, My big pointer is if you're interested in neuro-ophthalmology, join Nanos. There's a resident trainee membership, and it's a great opportunity to learn more about Nanos, about neuro-ophthalmology, and get connected to the community. Consider talking to your program leadership, residency mentor about when is the best time to have a neuro-ophthalmology rotation. One of the most difficult things sometimes is that it is required in ophthalmology. So in many cases, you don't have much flexibility about when you're going to be doing that rotation. But in neurology, it's not required. And so you actually probably have to seek it out a little bit and find opportunities to do it. The vast majority of programs have a neuro-ophthalmologist on staff. So finding someone to do a rotation with should be not too difficult. And if there's a neuro-ophthalmologist at your institution, introduce yourselves. I'll say that during my residency, I found it, I'm a neurology trained neuro-ophthalmologist. I found it very helpful to work with our neuro-ophthalmologist there. She would introduce me to all sorts of different cases, interesting articles, and it was just very helpful to have that as just, kind of as a point person throughout my residency. Start thinking about fellowship programs. The webpage for Nanos has a list of all of the different fellowship programs and the requirements and all of that. If you are interested, make sure to check out that website. It's very, very helpful. And start thinking about the San Francisco match. So as of this year, we are now participating in a fellowship match. And this is for 24-25 fellowship positions. Both ophthalmology and neurology residents are going to go through this match, through the San Francisco match. And the vast majority of the programs are accepting both neurology and ophthalmology resident trainees. There are some non-AUPO, those are it's a separate certification board. And there are some programs that are still outside the match. And it includes some neuro-ophthalmology programs and some international research positions. So if you are looking for something like that, those are still outside the match. And you have if you're interested in a program like that, there is some flexibility program by program. The deadlines and requirements are going to differ a little bit by program, so do make sure to review those. All right, and so just as a quick note, all of these PGY 2 years, this is for the United States residency programs if you are international or Canadian. So those are going to be your final, PGY 4 will be the final year, so +1. Anyway, so during your PGY 2 year, you want to explore all the possible specialties, but strongly considering neuro-ophthalmology. In your PGY 3 year, I would recommend that you decide to apply to neuro-ophthalmology fellowship and prepare your application. The early PGY 4 year is when programs are going to have you putting in your applications into the San Francisco match. And most of the due dates have been for late August. That's for this year. Obviously, for the year that you decide to go through the match, you're going to want to pay very close attention to the separate due dates. And then the match for this year is going to be in December. So we'll be interviewing in between August and December with the match occurring then. And then you have the rest of your PGY 4 year or final year to get ready for fellowship. So with that, I'll finish my comments and I look forward to our panel discussion.
Amy, that was really great. And I think it may be a lot for everybody to consume. So if you go home and you have questions later, or you're probably at home, if you have questions later, feel free to reach out to Amy, myself, or Julie via email. And if we don't know the answer, we can connect you to the right people. So let's bring on our entire panel. Everybody come join us, please. And so let's start by circling back with the question that Vivek asked earlier, which is how does the panel advise a trainee who may be interested in neuro-ophthalmology but is concerned about the finances? What do you say?
Can I start?
Go ahead, Vivek.
Whoever. Okay, I just said my perspective is this. I think that in neuro-ophthalmology, generally speaking, the finances within ophthalmology, I'll speak about ophthalmology, it's less than retina, it's less than oculoplastics, it's less than cornea, it's usually less than exclusively anterior segment surgeon, just because of volume. And we know that usually procedures pay more than cognitive specialty. Ophthalmology, in neuro-ophthalmology, it is possible to combine it with something else, whether it's comprehensive ophthalmology, even if you are not a cataract surgeon, just seeing more volume of patients, not exclusively, but as part of the mix. If the financial aspect of it, the difference is a problem, then one can do that. For example, a glaucoma specialist that doesn't do surgery is going to have a more comparable salary to a fully clinical neuro-ophthalmologist. It has more to do with procedures than not. As somebody who does strabismus surgery, if I didn't do strabismus surgery, my income would be a lot different than it is, but it still isn't what a retina person does because they don't have that kind of volume, right? But the point is that this divide between what a neuro-ophthalmologist traditionally would have made as an entirely clinical person, it's not as wide as it needs to be, or as wide as people often think it is, because I think people can combine it with either higher volume clinical work or surgical work, and there's many ways to do that. And now people are combining with other specialties and other subspecialties and other fellowships, but it can be done even within your own specialty, I think. So I think that the money part of it really doesn't factor in too much unless you're looking to have a very high level of income that can really only come with super high volume or some sort of cosmetic aspect, or something that's outside of the Medicare thing. The last thing I'll say is that many neuro-ophthalmologists have a lot of other interests because of their intellect and their knowledge. I mean, they're highly prized by industry. They can do medical legal consulting, which can be highly rewarding too in some situations. Probably not as an exclusive thing, but sometimes your opinions matter. But I know lots of people are super successful by offering their opinions to industry as well, and they can do very well with that from a financial perspective.
Brad, you have your hand up first. What do you think?
Yeah, the other point that I was going to make is that when you're trying to sell yourself to find a job, you're trying to sell yourself to your potential boss. Neuro-ophthalmology patients, as everybody has said before, take a lot of time. And if you can take those time-consuming patients off the hands of the comprehensive ophthalmologists, the retina specialists, the glaucoma specialists, then those specialists can be more efficient and see more patients and do more surgery. So some of the reimbursement that you get from your department or your practice needs to come, in a way that recognizes that you're helping the other people in your practice be more efficient at what they're doing.
Great point. Shannon, you had your hand up next.
I think it's who you're comparing yourself to. So as a neurologist, I'm already in residency. I'm going to be in a neurology field. When you compare yourself to the other neurology fields, I'm paid by neurology. I'm not a neuro-ophthalmologist, neurology trained, paid by ophthalmology like some people. So I'm actually within the neurology department, and I'm making probably the highest within my group because I'm able to do visual fields, OCT, and I see a much higher volume than a general neurologist. So especially here at Stanford, some of our neuro-ophthalmologists are paid by ophthalmology, and their RVUs are on the lower side of all the ophthalmologists. I'm doing the exact same job. I'm paid by neurology, and I am one of the highest. I think I am the highest RVU earner on the neurology side. So because I can see a lot more patients, I can see 18 to 22 patients a day, which is very high for neurology. So I think it's really how you compare yourself. And so from a neurology standpoint, it's actually highly lucrative because we have a much higher volume than all the other neurology specialties. So I'm about where epilepsy is because they do a bunch of EEGs and things like that.
That's a great point. Fiona, you come from a neurology background. Did you have a comment?
Yeah, I only ever really cared about money when I had none. And I didn't have any money when I started out and married neuro-ophthalmology to MS in a fee-for-service model as a young person. So I think it's really important professionally for you to decide what you value, and then ask yourself if the place that you're trying to work values you as well. So that's a whole other conversation, because you don't have to be a neuro-ophthalmologist to kind of get, mishandled or shaken down, or perhaps not treated well. I don't think people should do neuro-ophthalmology if the chairman of their department or chairwoman wants them to do it. I don't think they should do neuro-ophthalmology if they want to become rich. I would argue you shouldn't do medicine at all if you want to become rich. There's so many easier ways to become rich than medicine. As you get older, and I'm older now, I'll tell you things that matter more than money are your time and your sense of purpose and how you get through your day. And I know that's really, really hard for people to appreciate when they're young and in debt, but I can tell you that time is the money that is the most valuable commodity in your life, to be with your family, to do the things you want to do, and to feel a sense of fulfillment in what you're doing. And I would just ask anybody on the call listening to just imagine where you're going to be in 20 years. And when I look at some of my colleagues, the richest colleagues I know, and I'm not saying, I mean, maybe it's wrong for me to say this, but I do find it. I've never met a neuro-ophthalmologist ever who said, man, I hate this. I don't know how I get through the day. I don't make enough money. But I have met a lot of really, really highly remunerated colleagues who are very unhappy in their role, because with that comes a lot of other burdens about running a business. And, you know, who are you singing to for your supper? And if it's to make money, that's great. Do something else. You can make a good living. I make a very, very good living, a little bit like Shannon said, because it took me a while to figure out that a salaried model worked best. And I went to a place that valued what I did. But in general, as career advice, if you wanted to become a bajillionaire, you should have rethunk that one about 6 years ago. And there's so many more things that you'll find gratifying in your career than just money.
And I may just add before we wrap up, I may be the only ophthalmology trained on this panel who does not do surgery. I do Botox injection, but I no longer do cataract surgery, and I don't do strabismus surgery. So I'm the non-surgeon ophthalmology trainer ophthalmologist. And I kind of have to agree with Fiona. I love what I do. And yes, my salary is probably definitely not the same as many of my colleagues in the field of ophthalmology, but I have a very comfortable income. And I think what matters to me is to have a very supportive chairman who recognize that we are seeing very complex patients, and I'm also involved, with different leadership role, and that's being valued. And I think what really matters is I get to do what I really love. And so I kind of have to agree with everything that's been said so far. It's 6:32. It's time to wrap up. I just want to thank all of our speakers. Thank you so much for joining us tonight. Thank you so much, Vivek and Heather, to work as our wonderful Q&A moderators. And thank you to all of you at home who joined us this evening. You will see a very quick survey at the end of the webinar. Please take just a quick moment to complete the survey. And on behalf of Nanos, thank you for attending and have a wonderful evening. Thank you.